Chapter 15 is addressing the next part of the cardiovascular system. And in this chapter, we'll discuss the blood vessels and the blood circulation. So the blood vessel is part of the cardiovascular system and is connecting the four chambers of the heart in order to form this closed system. The blood is transported through the blood vessels from the heart to the tissues and returned from the tissues to the heart. In this process, the whole blood is not leaving the vessels, and it's the entire quantity of blood is conserved inside the system. However, some components of the plasma and some tissue fluids can be exchanged at the level of the tissues through the capillaries. This is an overview of today's lecture. We'll cover blood vessels in terms of types. We'll describe the circuits and the structure of the blood vessels. We'll present the systemic arteries and the branches. We'll describe the systemic veins and their branches. We'll discuss circulation physiology in terms of capillary exchange, elements related to the blood flow and blood pressure. And we'll discuss vascular disorders. Please stop the presentation and take a moment to review the learning objectives for this presentation. In big lines, we can divide the blood vessels into 5 groups. And those will be named according to the sequence of blood flow from the heart. And you can see that we have 2 main systems. We have the pulmonary circulation and the systemic circulation, both made out of arteries and veins and capillaries, and we'll describe each of those in detail. So let's discuss a little bit types of blood vessels. We'll start with the arteries, and this type of blood vessels will carry away from the heart and toward the tissues the blood. The heart's ventricle will pump the blood into the arteries that are thick-walled and large tubes. Also, in terms of structure, you will see that they are a little bit different than the veins when we'll discuss the vessel structure. The next type of blood vessels is called an arteriole, and they are smaller subdivisions of the arteries, and they will carry the blood from the arteries to the capillaries. So those type of vessels are the intermediate type in terms of diameter. They will narrow slowly and will become smaller and smaller in terms of branching out from the arteries while they are connecting between the arteries and what at a certain point will be the capillaries. The arterioles have the capacity of increasing and decreasing their diameter in order to control the blood pressure and also to control the distribution of blood amongst different types of tissue in our body. We have the capillaries, will be the next type of blood vessel that are very thin-walled and very narrow, and they represent the site of exchange between the blood and the tissues. Because of that, in their structure, you will see that they have only one layer of cells. The next type of blood, the type of blood vessel, will be the venules. That they are small vessels that receive the blood from the capillaries and will transport them towards the heart through becoming veins by branching in. If the arteries are branching out into smaller arteries and arterioles and they become eventually capillaries, capillaries will start branching in, becoming venules and smaller veins and bigger veins that will return to the heart. So the veins are thin-walled as opposed to the arteries that have a thick wall. They're also large tubes, and their main function is to carry back to the heart the blood. We'll describe now the blood circuits, and when we are looking at the whole blood circulation in our body, it can be subdivided into the pulmonary and the systemic. And pulmonary obviously is named like that because it will carry the blood to the lungs and will bring it back to the heart. And in the pulmonary circuit, the blood will be delivered to the lungs, and at the level of the lungs will take place the exchange of carbon dioxide that is eliminated, and the oxygen will be replenished, and through the pulmonary vessels, the blood will be returned to the heart. In terms of branching, we start at the right atrium. And again, if you remember, I was telling you that the left side is the deoxygenated side. So that's why it's colored in blue, while the right side is the oxygenated side, and that's why it's colored in red. And if you really follow the arrows, you will see that I was telling you that we can retrace the blood circuit connecting those two systems because they are interconnected by drawing the number 8. So if we are starting into the right ventricle, through the pulmonary arteries, the deoxygenated blood will be brought to the lungs where the exchange will happen. Carbon dioxide will be eliminated and the oxygen will be replenished into the blood and will be returned to the heart through the veins. And the veins will carry oxygenated blood into the left atrium. Remember that we have 2 pulmonary veins per each lung. From left atrium, the blood will be passed into the left ventricle, that through aorta will be distributed now into the systemic circuit. And the systemic circuit will distribute the blood everywhere in our body, up and down from head to toes, at the level of the tissues, everywhere in our body through the capillaries. The exchanges will take place again while the oxygen will be eliminated from the blood at the level of the tissue and will be used by the tissues, while the blood will be will carry back, will get from the tissues the waste products, mainly carbon dioxide. In this case, when we discuss this now, we'll discuss more the waste products when we'll discuss the urinary system. But we can consider carbon dioxide also as part of the waste, metabolized waste product. And the blood will be returned through 2 main veins to the right atrium through the inferior and superior vena cava. Now, from the right atrium, the blood will be pushed again into the right ventricle, and our cycle, our circuit closes here. We'll discuss now the vessel structure, and the structure will be a little bit different depending on the type of blood vessel. And by looking at their structure, we can understand their function. While the arteries will have thicker walls, the veins will have thinner, and the capillaries will have very basic type of structure, only a few elements that allow for a quick exchange. So you'll see how all this makes sense. Now, in general, as I was telling you before, in our body, a lot of things happen in a number of 3. So the blood vessels have a 3-layered wall. And they kind of resemble, if you really look into that, the 3 layers that we found in the heart. So if we are looking from external, from the outside to the inside, we have on the outside the outer layer that is supporting connective tissue. We have the middle one that is the muscular level, is made out of smooth muscles that are involuntary. However, they are able to contract and relax, and by doing that, and you can see how thick it is. Pay attention to the blood vessel in your image on the left side. That's an artery. You can see how thick the muscular level is, and you can see the middle layer. You can understand how by contracting or relaxing, the diameter of the vessel can change dramatically. And we have the inner layer that is a smooth lining of simple squamous epithelium, very, very simple epithelium that is called an endothelium. And on this smooth epithelium, on purpose, it's like that because we want to have what is called a laminary, a smooth flow of the blood, and nothing will bump into the particles that are dissolved in the blood or carried in the blood and create a blood clot because of that. Now, if we're looking into the capillaries, you see how the arterioles, they still have the muscle layer. However, if we are moving into the capillary level, the only thing that stays will be what is called the basement membrane and the endothelium. What disappears is the thick layer of the muscle that we see in the artery. Now, when we are moving into the venule, the venules and the veins will regain a muscle layer. However, it's very, very thin. It's almost under, it's very underrepresented, very hard even to observe. And its function, even if it's trying to contract or dilate, it will not going to make a big difference in terms of flow. Something else that happens, and it's important in the veins, is that they have, if you see, they have what is called a valve, and those valves, because most of the veins will be pushing blood against the gravity, the valves will prevent the reflux, the backflow of the blood back due to gravity in between the heart contractions. There is a tissue that is very elastic, and that will allow it is situated between the layers of the arterial wall, and this will allow the vessels to stretch, and when they are receiving the blood, when the blood is pushed from the heart and it's pumped out, the artery will expand a little bit because of that pressure. And the easiness with which a vessel will expand when receiving the blood is called compliance. Now, the elasticity is that ability of the same vessel of pushing back the blood once the pressure is not increased from the heart, and to allow the artery to return to its original size after being stretched by the blood pumped inside. By having a compliance and then an elasticity capability, the artery is actually able to propel the blood forward between the heartbeats. And by doing that, to ensure that there is a continuous flow and it's not stopped in between the heartbeats. The amount of elastic tissue will become smaller and smaller as the arteries are branching out, and they are becoming smaller and smaller. And at a certain point, the small subdivisions, the arterioles, have a very thin wall with almost inexistent, very little elastic connective tissue. However, at this level, we have a little bit more smooth muscles, and that's why the arterioles have this great capacity of contracting or relaxing, vasodilating or vasoconstricting, and by doing that, to regulate the amount of blood that will enter a specific type of tissue at a given time. Question number 1. Which tissue makes up a blood vessel's inner tunic? The smooth muscle, the epithelium, the connective tissue, or the nervous tissue? The tissue that makes up for the blood vessel's inner tunic is called epithelium. We'll discuss now different types of blood vessels, and we'll start with the systemic arteries. The systemic arteries, when we are looking at the systemic circulation, will always start with a big blood vessel that is called the aorta. It's the largest of the artery. It has about 1 inch in diameter. That's about 2.5 centimeters. And aorta starts at the level of the left ventricle. Will have an ascending trajectory out of the heart, will go upwards towards the head, will arch back, and will start traveling down through the body, and by doing that, it's able to branch out and cover and supply blood flow to all the organs. So because it's such a big artery and such an important one, has a very thick wall, and it's a continuous artery. However, it can be described and can be from a theoretical point of view, we can describe 3 different areas in the aorta. From the level where it starts in the left ventricle up to the point where it starts to curve, we call that part the ascending aorta. It ascends, it lifts itself up. And the beginning of this part is presented, it's included in the pericardial sac. After that, we have what is called the aortic arch. It's exactly that arch that the aorta, it's the curvature of the aorta that this blood vessels is making a little bit from right to left, and it goes from anterior to posterior if I really need to describe it. The next part will be the descending aorta because it goes down, descends in our body. And at the level of the descending aorta, we describe two parts. We can divide it into the thoracic aorta that will descend just anterior to the vertebral column in close contact with the bodies of the vertebrae. That is posterior to the heart and inside the space of the chest that is called mediastinum. And we have the abdominal aorta that is from the point where the aorta is crossing under the diaphragm, from the diaphragm until the end of the aorta in the pelvis. That part is the descending abdominal aorta. In its way, aorta will give out many branches, and I will describe them. We'll start discussing now the aortic branches, and we'll start from the root of the aorta with the ascending aorta. And when we are following those images, please try and follow them from the origin of the blood vessel and just follow the trajectory of the blood vessel. For the aorta, we'll start on the left side of it. And when we are looking at the ascending part, if you remember from the heart, I said that the only two branches that are coming out of this area of aorta, they are the left and right coronary artery that supply oxygen and nutrients to the myocardium. At the level of the aortic arch, that is immediately at the level of curvature, when the curvature starts, the first division, the first branch out will be called the brachiocephalic artery, which is pretty thick and short. After about 2 inches, it will divide into the first branch that is called the subclavian artery, which will extend under the right clavicular area, under the right clavicle, and will supply the right upper extremity. And also will supply part of the brain through the right common carotid artery. That will divide into the right external and right internal carotid artery for the right side of the neck, head, and the brain. So important for this artery is to see that this is an unpaired artery. It's not a couple. The second branch from the aortic arch will be the left common carotid artery that will have a trajectory upwards, and it will supply the left side of the neck and the head through the left internal and external carotid artery. The third branch will be the left subclavian artery that will extend under the left clavicle and will supply the left upper extremity. This is the last branch of the aortic arch. Now we are going into the descending aorta, and we will look first at the thoracic part of it that will provide small branches to the chest wall and the esophagus, branches for the bronchi that are subdivisions of the trachea. We'll discuss that in the respiratory system, and to the lungs. So the lungs are receiving their nutrients. The tissue will receive their nutrients and oxygen through the branches from the thoracic artery. However, the lungs are flushed all the time through the pulmonary artery and capillaries, and after that through the pulmonary veins back to in the pulmonary circuit, just for the function of the lungs. Usually we have 10 pairs of intercostal arteries that will extend in between the ribs and will send branches out to all the muscles and the rest of the structures of the chest wall. And when I say the other structures, you can think about the, let's say, mammary gland. We are looking now at we are getting lower, we are passing inside the abdominal cavity, and now we are discussing the abdominal aorta. And for abdominal aorta, we have two categories of branches. We have those that are called unpaired. It's a singleton branch, and we have those that are paired, and we will discuss them separate. So going up, down, we'll have the unpaired branches. First one will be the celiac trunk. That is a very short artery that will subdivide immediately into three branches. That will be the left gastric artery that will supply the stomach, splenic artery that will supply the spleen, and the hepatic artery that goes to the liver. We have immediately under this, we'll have the superior mesenteric artery that will carry blood to most of the small intestine and also to the first half of the large intestine, the right side of it. And we have immediately under it, we'll have the inferior mesenteric artery that is smaller in diameter, and it supplies the second half of the large intestine, the left half of the transverse colon and the descending sigmoid and the rectum. The paired branches of the abdominal aorta are very up on top under the diaphragm. We have the superior and inferior phrenic arteries that will provide from under and from above blood supply to the diaphragm. The next pair, it starts a little bit under the origin of the superior mesenteric artery. However, it is under the level of the inferior mesenteric artery. It's a pair of two large vessels that are the renal arteries that they are carrying blood to the kidneys. Gonadal arteries are the ovarian in females, ovarian arteries, and testicular arteries in males, and they supply the sex glands. They start under the superior mesenteric artery and before the inferior one. And we have four pairs of lumbar arteries that will extend in the and supply blood with oxygen and nutrients to the muscles of the abdominal wall. They are not represented in this image that you have in front of you. We'll discuss now the iliac arteries. When the abdominal aorta divides finally and it splits into two main arteries, those will become the common iliac arteries and are about 2 inches long and extend inside the pelvis, where they will subdivide again into an internal and an external iliac artery. Internal iliac artery, it's easy to remember what they are supplying. They are providing branches for the pelvic organs. They are going inside. And we are talking now about urinary bladder and rectum and reproductive organs. While the external iliac artery stays on the outside and will go towards the thigh, where will become femoral artery while it's passing under the inguinal ligament. The femoral artery will divide itself into the deep femoral artery at the level of the thigh, and after that, at the level of the knee will become the popliteal artery that in the leg and foot will give the tibial anterior and posterior tibial arteries. Those arteries at the level of the foot will become dorsalis pedis. Also, the posterior tibial artery will give a small branch that is called the fibular artery at the level of the leg. We'll continue to describe now the arteries supplying the arm and the head. And if you remember, we left those arteries at the level of the subclavian artery that we said that it supplies blood for the arm and the hand. The first branch that subclavian artery is given is called the vertebral artery. However, we'll describe that in the next slide. I would like now to continue with the subclavian artery that continues to travel through the arm, giving branches for the arm itself and for the forearm and hand. The first part of it at the level of the armpit is called the axillary artery. That will become the brachial artery in the arm itself, and at the level of the elbow, it will divide into radial and ulnar artery. Radial artery is one on the external, on the lateral side of the forearm, and the ulnar one is the one on the internal or the medial side of the forearm. Those two arteries will join together again and will form what is called the palmar arches that finally will give off very small arteries that are called digital arteries that will provide blood to the fingers and the hand itself. We'll discuss now the first branch and also the carotid immediately. So remember that I said that the first branch that the subclavian artery will give is called the vertebral artery that will pass through the transverse processes of the first 6 cervical vertebrae and will provide blood to the posterior brain. You can see how it bends over and gets at the level of the occipital lobe. The right and left common carotid arteries will travel along parallel on the sides of the trachea, and they will be enclosed in a sheath together with the jugular vein and the vagus nerve. It's kind of like a bundle. Just anterior to the angle of the mandible, the angle of your lower jaw, each of those branches will will branch out into an internal and an external carotid artery. The external carotid artery will provide branches for all the structures of the face, also the eyes, the scalp, and the internal carotid artery will travel inside the head and will provide branches from inside to supply the eye, the anterior portion of the brain, and some other structures inside the cranium. Now, the external carotid artery will also provide branches for the structures of the neck. You probably heard me in the previous lecture talking about anastomosis when we discussed the heart. So an anastomosis can be defined as a communication between two vessels. And usually we describe those mainly at the level of the arterial structures. Most of the organs that are vital organs and they need a rich blood supply will have a lot of arterial anastomosis to protect them from what is called hypovolume or hypoxia if one of those arteries will become blocked at a certain point. And we have a few examples of those. We have the cerebral arterial circle or the circle of Willis. I will describe this in the next slide. We have the superficial palmar arch where the arteries from radial and ulnar arteries are joining together and are communicating. And we have the mesenteric arches that we see at the level of the mesenterium as communications between superior and inferior mesenteric artery. Similar to the superficial palmar arch, we have the arcuate arteries that are at the level of the foot. I was telling you about the circle of Willis, which is a structure that receives blood from two internal carotid arteries along with the basilar artery. Now, the basilar artery forms out by the joining of the two vertebral arteries that are both coming, if you remember, from the right and left subclavicular arteries. So if you really need to look, you can see that we have the anterior communicating, anterior cerebral and middle cerebral arteries for the anterior part of the brain coming from left and right carotid arteries with the basilar that becomes posterior communicating and posterior cerebral arteries that is made out by putting together the two vertebral arteries that are coming from the subclavicular arteries. So we have more than one source of blood supply that is trying to supply and kind of meet the needs of the brain at any given moment. Question number 2. Which vessel supplies oxygen-rich blood to the stomach, spleen, and liver? And your options are A, hepatic portal system, superior mesenteric artery, inferior mesenteric artery, or the celiac trunk. The answer is the vessel that supplies oxygen-rich blood to the stomach, spleen, and liver is the celiac trunk. The veins. Now, once we have all the arteries branching out and they become at the level of different organs and tissues, they become arterioles and finally capillaries, they will join back to form venules and finally veins. And I'll describe the systemic veins. Probably you noticed that the arteries, because they are so important in providing oxygen to the tissues, bringing in the nutrients, they are located in areas that are a little bit protected in deeper areas in most of our parts of our body. It's not the case with the veins. The veins are mainly found on the surface. They are more superficial. And I will start by describing the superficial vein system. So we have veins on the back of the hand, at the front of the elbow, and those will be the veins that usually are easily accessible for IVs or for blood testing purposes. And the largest of this group will be your cephalic. You can see it on the in the image, cephalic, basilic, and the median cubital veins. We have also the superficial veins of the foot. That will be the leg and foot. That will be the saphenous vein on the lower extremity, and it's probably the body's longest vein. The great saphenous vein begins somewhere in the foot and will extend up on the medial side of the leg and the knee and the thigh, and finally will enter the femoral vein near the inguinal region or the groin. We also have a system that is deep. So if the arteries were all deep in one system, for the systemic veins, we'll have two systems. We have a superficial one and the deep one. The deep one will parallel the arteries, will travel along with the arteries, and they usually have the same names as their corresponding partners. We have femoral vein that travels with the femoral artery. We have external and internal iliac vessels that travel with the internal and external iliac arteries. We have radial, ulnar, brachial, axillary, and as they branch in, subclavian vessels for the upper extremity. Now, at the level of the neck, we have the jugular veins. By the way, jugular in Latin means neck. That's why that vein is called jugular. The larger of the two veins in the neck will be the internal jugular, and it receives blood from the cranial venous sinuses and that drain the head, and also from some regions of the face and the neck. The external jugular, it's a little bit smaller and will parallel the external carotid artery. Both of them will empty directly into the subclavian vein. Now, on each side, the subclavian, external, and internal jugular will join together and will form a brachiocephalic vein. So, the brachiocephalic vein, it's a pair. There are two of them, while the artery, we have just one. We'll discuss now the two large veins that receive blood from the systemic vessels and that are bringing it back to the right side of the heart to be reoxygenated through the pulmonary circulations. The veins of the head, neck, upper extremities, and chest, all of them will be drained through the superior vena cava. This vessel results by putting together the right and left brachiocephalic veins. We have another vein that is unpaired. It's called the azygos veins that will drain the veins of the chest and will empty into the superior vena cava just before it will empty itself into the right. It enters the right atrium. The lower part of the body is drained by the inferior vena cava, which is way larger than the superior one, and it will return blood from all the regions, everything that is below the diaphragm. It starts to become the inferior vena cava in the lower abdomen by the branching in, by the connection between the common iliac veins that will ascend, and they will parallel the vertebral bodies in a groove in the posterior part of the liver and through the diaphragm to finally get in the thoracic cavity to empty into the right atrium. So below the diaphragm, we can divide the large veins into two groups. We have the right and left veins that will drain the paired parts of the paired parts or organs. That will be external and internal. Carotid iliac vein will be the common iliac veins. Will have four pairs of lumbar veins from the dorsal trunk. And from the spinal cord, we have gonadal veins that can be testicular in males and ovarian in females. And we have the renal veins that comes from the kidneys. In addition, we have large hepatic veins that are draining the liver. And those will empty directly into the inferior vena cava, all of them, with the exception of the left testicular vein that will empty into the renal vein before going into the cava. In addition to that, we have some unpaired veins that drain the spleen and parts of the digestive tract, and they empty into the hepatic portal system. And we'll discuss that separately because it's important to see how the veins from the digestive system will travel through the liver first in order to process whatever is absorbed at that level. So we will review the systemic veins for the lower body. If we start at the level of the digits of the foot, we start with the dorsalis digitals. That will become the plantar venous arch that will join together and will form the small saphenous vein for the superficial system, and will have posterior and anterior tibial for the deep one. That will become popliteal at the level of the knee. On the other side, we have on the medial side, the dorsal digitals and the plantar venous arches will become the greater saphenous vein that will empty inside the femoral vein. The popliteal vein will continue with the femoral vein at the level of the thigh that becomes the external iliac under the inguinal ligament. External and internal will connect and will become the common iliac that by joining the common iliac from the other side will become the inferior vena cava. We'll describe now the venous sinuses, and I'll start by defining what the sinus is. Sinus means a hollow space. So in other words, a venous sinus will be a large cavity, a hollow cavity that will drain blood that is low in oxygen. However, that structure will not going to be a typical vein tubular structure. We have a similar type of a structure like this that is called the coronary sinus that receives the blood from the heart wall. However, when we look at the cranial venous sinuses, they will be placed in between the two layers of the dura mater. If you remember, dura had two layers, one that was tight connected to the periosteum of the skull, and one that was the layer covering the arachnoid space. Veins from everywhere in the brain will drain together in those channels that are not per se structures, round structures like the veins will be. They also collect, if you remember, the cerebrospinal fluid that by doing that is returned to the bloodstream and can be filtered and renewed in the kidneys. The largest of those sinuses will be described, and you can see them in the picture. We'll start with the superior sagittal sinus. It's the first one just under the skull, which is a hollow space that is long and located in the midline above the brain. and inside the fissure between the two cerebral hemispheres, just crosses inside that space. And it will end up at the portion that is called the confluence of the sinuses. And it's called the confluence because all the sinuses are joining over there. We have also the inferior sinus, sagittal sinus, and it's called sagittal because it's in the middle, obviously, that parallels the superior sagittal sinus and will merge with the straight sinus, which is the third one that receives blood from the large cerebral veins, and will confluent all of them at the confluence of the sinuses. We also have two transverse sinuses that are also called the lateral sinuses that begin posterior and will extend lateral. That's why they're called lateral sinuses. And it will leave the brain eventually to open in one of the transverse sinuses. Each of those venous sinuses will eventually empty into internal jugular vein, and from there will be passed down the neck towards the superior vena cava. We'll discuss now the hepatic portal system. If you remember, we had the portal system at the level of the pituitary gland, and this is it can be described in general terms as a system where the blood will pass through two different capillary beds before being returned into the venous system. Usually in a normal tissue, we'll have arteries, arterioles, capillaries, venules, veins. In a portal system, we have a first level of capillary structures that will become veins, and instead of draining into the one of the cavas, will become again a structure of capillaries. So by doing that, portal circulation will allow for some of the products that one specific organ is producing to be rerun through a secondary organ. And you will see how that applies to the portal system. So if you're looking at the blood supply, how the veins are branching in. The branches from the stomach and from the small bowel will all branch together. And this type of vessels will carry all the absorbed nutrients from the stomach and the small bowel. So instead of returning that directly to the cava, they will be filtered, they will be evaluated in a structure of capillaries inside the liver. So we have the splenic vein, the gastric, pancreatic, inferior and superior mesenteric vein, that they will all join together to make a big vein that is called the portal vein. And instead of connecting directly to the cava, this portal vein will enter the liver. At the level of the liver, will branch out again, becoming a very well-developed network of sinus-like capillaries that are called sinusoid capillaries. And they're a very specific type of capillaries. They have wide gaps in their structure that allows them to leak outside and allow for a free exchange of proteins and nutrients and all those substances with the hepatic cells, with the hepatocytes. And as a result of that, the hepatocytes may process those nutrients or may clean out some toxins that we may ingest. Once all those elements are processed, the blood from those capillaries will branch in and will form what is called the hepatic vein that will join the inferior cava and will leave the liver towards the right side of the heart. We'll discuss now the circulation physiology, and that includes a few processes. But if you really need to look in it like a macro type of observing it, the circulation is actually a transportation of elements. We'll transport the gases from the lungs to the tissues, and from the tissues back to the lungs, will transport the nutrients to the tissues and the waste products away from the tissues and towards the kidneys, where they will be eliminated. So in this process of transportation, we also have the element of exchange. And there are three processes that we'll discuss. It will be the level of the capillary. We'll have the diffusion, we'll have the bulk flow filtration, and we'll have the bulk flow absorption. That's the processes through which the capillary exchange takes place. So the diffusion, if you remember, it's a passive process. And the driving force for that will be the concentration. If I have a component that has a higher gradient, a higher concentration, that component will move through the membranes from the higher concentration to the lower concentration to equalize the gradients. So most of the time, the direction of movements for those diffusions will be blood to interstitial fluid. However, we have also the cells to interstitial fluid, and from interstitial fluid to blood for the waste products and the CO2. The blood to interstitial fluids will be oxygen, nutrients, and electrolytes. Just to remind you, what is the interstitial fluid or the tissue fluid? I would like to move to the next slide so you can see the diffusion process a little bit more in detail. So you can see here the capillary exchange, and you can see that every single living cell is connected with other cells at different points. However, is also submerged, immersed in a type of liquid that is called the interstitial fluid or the tissue fluid, and is that part of our body that serves as the middleman or the intermediate part where all the exchanges are happening in between the capillaries and the interstitial fluid, and in between the interstitial fluid and the cells. At this level, we have the exchange of the water and oxygen and electrolytes and nutrients moving freely if it's a diffusion process based on their concentration. At the level of the capillaries have a wall that puts a limit in between the blood and the interstitial fluid, and their tightness of the cells that make up for the capillary wall will be different in different tissues based on their intensity of exchanging. Let's say that will give you an idea about how effective a tissue is. For instance, we have those in the bone marrow, and those capillaries are very leaky, have big gaps in their structure. So they allow the new cells to pass through those spaces and move from the bone marrow tissue inside the capillaries. On the other hand, the capillaries at the level of the brain, if you remember, they are very tight and they restrict the passage of the substances, and they need the astrocytes to be the intermediate over there. In the capillary exchange that is a passive diffusion, you can see at number 3, that's the example of it. You can see how in between the cells, those substances that are able for the to perform what is called the simple diffusion, they are moving back and forth through the membrane. We have also, if you look at number 1, it's a different type of diffusion, and that's called facilitated diffusion. That instead of going in between the gaps, in between the cells, it will be through the help by using a cell that will engulf that particle and eliminate it on the other part and the other side. And we'll discuss in a second what is called the bulk flow. So when we are looking at the bulk flow, that will be a movement of the fluid across the capillary wall down a pressure gradient. So what I'm trying to say with that is that a gradient will be a measurement of how two pressures are balanced with each other. And at the level of the capillaries, we have two types of pressure. We have the hydrostatic pressure. Hydro means water. So the hydrostatic pressure is that pressure given by a fluid that contains a lot of water. That will be the pressure in the bloodstream, the pressure given by the blood. And we have the osmotic pressure. And the osmotic pressure is given by the amount of albumin that exists in the blood also. So there is a difference between the hydrostatic pressure given by the water component and the osmotic pressure that is given by the amount of albumin, by the proteins that exist in the tissues. So whenever I have a hydrostatic pressure that is higher than the osmotic pressure, I will have what is called a filtration. The water being higher than the osmotic pressure will pass from the capillaries inside the tissues. And whenever this hydrostatic pressure will be lower than the oncotic pressure, I will have a reabsorption of water. I will have water being collected from the tissues back inside the blood vessels. At the level of the tissues, most of the lymphatics will collect any type of excess. So if you're following with this image, you will see how the blood flow at a certain point, the hydrostatic pressure is higher than the osmotic one when we are entering inside the capillaries. So a lot of the fluids will be filtered out from the capillaries and will exist inside the tissues, in the interstitial tissue, up to a point that the capillary hydrostatic pressure will be very low. And at that point, the absorption, the recollection of the fluids from the tissues will be returned. Now, there is always a little bit more fluid that stays in the interstitial tissue than the one that is absorbed back. And for processing of that excess fluid, the lymph vessels that they really look like this, they are end out like a finger. They are not connected to anything else. They just have this kind of finger-like terminations in the tissues, will collect the result of this. So we're not going to have edema of the tissues as a result of increased filtration down the pressure gradient. The blood flow is continuously regulated in order to supply the tissues with their necessary nutrients and oxygen, as well as removing unnecessary waste products. Also, the requirements of blood supply may change throughout the day or may be different from one organ to the other. For example, a muscle need can increase in exercise up to 25 times as opposed to a muscle that is completely relaxed while we are sleeping. In addition to that, the increased needs will need to be reflected in an increased cardiac output. The heart will need to pump more. And the way that the circulatory system is ensuring an adequate blood flow is by using the vasomotor changes. And those will be the vasodilation or the vasoconstriction. By increasing the internal diameter, especially of the arterioles, but all the arteries are able to do that, will produce what is called the vasodilation, while the decreasing of the diameter will produce a decrease in the blood flow, and that is called vasoconstriction. There is a vasomotor center in the medulla of the brain, and that's one of those primitive structures that are common for us with other animals. It's not related to our cortex, it's totally involuntary. And that part of the brainstem will regulate all the changes in the vessel diameter by sending out messages through the autonomic nervous system. Also, there is another structure that is called the precapillary sphincter. Sphincter is a circular tiny muscle that may constrict or dilate in order to regulate the passage of a fluid through that area. The precapillary sphincters that are at the entrance of each capillary, they are controlling the blood supply to that area, to that capillary. And by doing that on a wide web of capillaries, we can very quick coordinate by increasing or decreasing the flow in a certain organ. The return of the blood to the heart depends on several mechanisms, and mainly that happens because the blood pressure drops throughout the branching out of the arteries up to a point that at the level of the veins becomes zero. And as a result of that, we need some mechanisms that will help to overcome the forces, and especially the gravity that works against the upward flow that needs to be present from all those regions that are below the heart. And there are three mechanisms that help the blood to return to the heart. One will be the contraction of the skeletal muscles. And once the skeletal muscles, as you can see in these pictures, are contracting, they will compress the vein and will squeeze the blood towards the upper parts of the vein. Another mechanism will be the presence of the vein in all those veins, presence of the valves in the veins everywhere under the diaphragm. And those veins will prevent the backflow and will keep that blood flowing towards the heart in a more steady type of movement. And the third mechanism that helps to kind of suck up the blood and move it upwards towards the heart is the breathing pattern. The way that we are breathing, and in the process of breathing, the pressures are changing both in the abdominal and in the thoracic cavities. And that allows for a decrease, becoming a negative pressure at the level of the thorax that will kind of suck in layers of blood from the veins under the diaphragm. Question number 3 is asking you which term describes the movement of fluid down a pressure gradient. And the options are A, endocytosis, B, exocytosis, C, bulk flow, or D, diffusion. The term describing the movement of fluid down a pressure gradient is called bulk flow. The blood pressure is the force that is exerted by the blood against the walls of the vessels, and is the result in the beginning of the force propelling the blood from the ventricles, and it decreases throughout the branching out of the arteries. The pressure in the blood vessels therefore declines with increasing the distance from the left ventricle. And at the level of the vena cava and actually back into the right atrium, when we are going through the vein system, the pressure will be almost zero. The blood pressure is controlled through a negative feedback loop and is determined by a few elements. It's determined by the total blood volume, by the cardiac output, by the resistance to blood flow, and by the blood vessel compliance and elasticity. Before we describe more about the blood pressure regulation, there are a few elements that we'll need to define here. And first of them will be the systolic pressure. We call systolic pressure the maximum pressure that develops in the arteries during the heart muscle contraction. That's why it's called systolic, because it's measured in the systole of the ventricle. We define as diastolic pressure the lowest pressure that will be measured in the arteries during the relaxation of the heart muscle, therefore in the diastole. The mean arterial pressure is the average pressure in the arteries, and the value will be closer to the value for diastolic pressure than for the systolic pressure, because in the diastole, it's a little bit longer than the systole. The pulse pressure is defined as the difference between the systolic and the diastolic measured pressures. It represents actually the pressure increase in the vessel that is created by the ventricular contraction. And again, the pulse pressure declines to about zero when it reaches the capillaries. It equals itself. We have another element that is called the pulse beat. And the pulse beat can be felt in any artery that can be reached from the surface of the skin. And particularly that will happen in the vessels that can be compressed against the bone. They are superficial. A few places where we can measure the pulse beat will be at the level of the wrist, where the radial artery will be. We can compress it with the thumb against the radius. Other vessels where we can take the pulse will be the carotid artery at the level of the neck, dorsalis pedis on the top of the foot, the femoral pulse in the groin. So each pulse beat represents, in fact, one cardiac cycle. So in a healthy individual, the pulse rate will be equal to the heart rate. However, the heartbeat may not always be detected as a pulse, especially if the heartbeat is very weak, or if the artery, the specific artery that we are trying to measure the pulse or determine the pulse over there, is obstructed. Short-term blood pressure regulation. As I said before, there are many elements that will regulate the blood pressure. And our body, in terms of homeostasis of the cardiovascular system, is trying to keep the blood pressure into a very narrow limit without big fluctuations. And this in order to not damage the blood vessels or to overwork the heart. We don't want to destroy the vessels, the circulation vehicle, and we don't want also to overwhelm the pump. So specifically, the body will regulate the pressure, the blood pressure at the level of the arteries. So as we described before in the previous lecture, the cardiac output will be the result of multiplying the heart rate by the stroke volume. So let's look a little bit into those elements. We have the control for the short term will be provided by a negative feedback loop, and the blood pressure needs to be maintained constant despite any type of body changes, body position changes, or changes in the overall amount of blood volume. And this is can happen by using some sensors for the blood pressure, and they are called baroreceptors. Baro means pressure, so they are receptors that are feeling changes in the pressure on the walls of the carotid artery, and also they are present in the aorta. Those receptors are what is called stretch receptors. So they will be activated when the pressure will stretch the vessel walls, and they will transmit an impulse. Also, the moment that the pressure will decrease in the same area, the signal that is transmitted by those baroreceptors will decrease. And the example for a decrease in pressure is when a patient is bleeding, and as a result of the hemorrhage, the blood pressure will be reduced, and the signals that are lower in intensity will be transmitted to the medulla oblongata. Over there, we have a center that will respond to this stimulation by increasing the sympathetic activity. And as a result of the sympathetic activity, the sympathetic nervous system will increase the heart rate and will increase the stroke volume. In addition to that, the same system will produce vasoconstriction. And the result of all three elements will increase the blood pressure. So again, we'll review the same thing. The moment that the blood pressure will decrease, will be sensed by the baroreceptors that are not stimulating enough, and the signal is perceived by the cardiovascular control center in medulla oblongata that through the sympathetic nervous system will produce three effects. Will increase the heart rate and will increase the stroke volume. The heart rate will mean the heart will start beating faster, and the stroke volume is the force that the heart will push the blood outside, in addition to the fact that will vasoconstrict will decrease the diameter of the blood vessels. As a result of those changes, the blood pressure will be stabilized. I'm not saying will be increased, will become stable, because right here it's low, and all those mechanisms are trying to stabilize to normal values and not to just increase or decrease. On the other hand, the long-term blood pressure regulation is determined by the regulation of the total body fluids. And this because changes of this parameter, the fluid that flows inside the blood vessels, will directly and profoundly affect the total blood volume. So in order to understand that, we need to define how much out of the total body volume will be the arterial blood. And the arterial blood represents about 13% of the total blood volume in a resting person. However, if the total blood volume increases, the arterial blood volume and thus the blood pressure will increase with it. And I will give you an example. Let's say when a person is having a diet that has it's high sodium diet, the sodium will stimulate the thirst center in our brain, and as a result of that, the same person will ingest a lot of water, so will increase the water retention, and as a result of that, the total blood volume. If there would have been no compensatory changes, the arterial volume and as a consequence, the blood pressure will also increase. So the kidney will start taking care of this change and will start altering the level of fluids together with the level of sodium in order to maintain the blood pressure. Another element that is reflecting and will influence the arterial blood pressure is the blood viscosity. Blood is a fluid, and the more viscous a fluid is, the higher will be the pressure that the fluid will exert on the walls. In normal circumstances, the blood viscosity is constant and is determined by the amount of particles that are dissolved or transported in the fluid part of the blood. However, whenever we have loss of red blood cells, as in anemia patient, or or loss of plasma protein, that will decrease the number of particles, and as a result of that, the viscosity will be lower. And as a result of that, the blood pressure will be lower. As opposed to that, if we are increasing the number of red cells, as in a condition that is called polycythemia rubra, or we have a loss of the plasma volume, not the plasma proteins that are dissolved in the plasma, but the plasma itself, the fluid part of the blood, as in dehydration, those elements will increase the viscosity, and as a result of that, the blood pressure. Another element that is contributes to increasing or decreasing the arterial blood pressure is the blood vessel compliance. And it's important to remember this element of the blood vessel compliance when we'll discuss degenerative conditions and diseases associated with the cardiovascular system. You will see how compliance is changing in those patients. So the compliance is the easiness by which blood vessels will expand to receive blood, and they will get charges with part of the kinetic energy of the blood that is pushed into them. If the blood vessel will lose this capacity of expanding, like I was telling you in atherosclerosis, the same volume of blood that enters the arteries will create a greater pressure because they are not elastic, they are not gaining part of that pressure and that energy, and they will be confined in a smaller place. The blood vessel will lose compliance with aging, and as a result of that, the blood pressure will increase with age. Let's summarize what's happening and how is maintained the blood homeostasis, especially the one that is the short term, like in an acute condition. And we'll start at the bottom of the picture where it says start here with the blood loss. As a result of blood loss, we are losing both particles and fluid. So it's an acute loss, will be a reduced blood pressure that will decrease the stretching of the receptors inside the carotid artery and in the aorta. Those receptors will decrease transmitting signals to the medulla oblongata in the brainstem. As a result of that, another center in the same place that is the stimulating sympathetic center will increase the signaling, the signals through the sympathetic nervous system to the blood vessels, creating vasoconstriction, reducing the diameter of the blood vessels, and signals to the heart by increasing the number of contractions per minute by stimulating the sinoatrial node. In addition, other fibers will stimulate the ventricular fibers, the muscle itself, to contract stronger. When the heart is contracting stronger and faster, we have an increase in the heart rate and the contraction strength, and as a result of that, we have an increased cardiac output. When the blood vessels become constricted, we have an increase in resistance, so a lower compliance. A combination of those two elements will increase the blood pressure and will restore the normal blood flow for those organs that are essential for surviving as the brain. It will not going to solve the problem, however, it will not going to solve the blood loss. We need to solve the main issue that generated the decrease in blood pressure in order to save this patient. How do we measure the blood pressure? So it is important to know exactly what values our blood pressure has. And you see that by measuring blood pressure, we can get very important information regarding the well-being of a patient or a person. Blood pressure together with the pulse is considered part of the vital signs. The most common place where we are measuring the blood pressure will be the arm by measuring it at the level of the brachial artery. We are measuring both systolic and diastolic pressure, and we do that by using an instrument that is called a sphygmomanometer, or how it's called in the field is called the blood pressure cuff. This a sphygmomanometer will have a cuff that is placed on over the brachial artery that using an inflator will inflate and will put pressure on the artery. The pressure will increase up to the point, and we can measure that pressure because we have a pressure gauge that is connected to the blood pressure cuff. The pressure in the cuff at a certain point will collapse the brachial artery, will impede the blood flow, will not allow the blood to flow through it. Using a stethoscope, we are listening and we are releasing slowly the air from the cuff. And while listening with the stethoscope, we are looking for what is called the Korotkoff sounds. And those sounds will start as a faint swishing. The first value, when we hear the swishing, as the blood starts to pass through the decompressed now artery, will be called systolic pressure when the sounds appear. We'll keep continuing the swishing sounds that will become stronger and stronger and stronger up to the point that they will become faint again and they will disappear. The moment we are registering the value when the sounds disappear, and that will be considered, will be noted as the diastolic pressure. On an average and as a normal part of blood pressure, we call a normal reading a value of 120 over 80. That's how we express it. As a general rule, when we are looking at that, the systolic pressure will be that pressure that the heart is producing in the blood pressure in the blood vessels during the contraction, while the diastolic pressure will be that pressure that we can measure in the blood vessels when the heart is relaxing, is not contracting at all. We'll have now abnormal values. And the abnormal values can be lower or higher than what we consider a normal value for a certain age and a certain person, because the values will vary throughout our age. The values will slowly increase since infancy to adulthood. Whenever the value is higher than expected, it's called hypertension. And when it's lower than expected, then normal blood pressure will be called hypotension. There will be normal variations related to what is called the posture, depending on how we evaluate it. If a person is sitting or lying supine on a bed. The hypertension is the one that we are more concerned of, because if it's temporarily as a result of excitement or exertion, will not going to be a big problem. However, if it's sustained over a long period of time and it doesn't go back to normal values, it may affect different other organs in our body. It may affect the kidney and produce what is called a kidney damage, or it can affect the brain and the blood vessels. However, other organs, if diseased, may create an increase in the blood pressure. Now, the kidneys, we know that they receive about 20% of the cardiac output each minute. A fifth of the blood flow will go through our kidneys with every heartbeat. So every type of condition that will affect the kidney and will affect the structure of the kidney and will prevent the blood to normally go through the kidneys will create an overwhelming pressure in the main system, and as a result of that, hypertension. There are conditions as endocrine disorders like hyperthyroidism or acromegaly that under the influence and activity of the hormones, there is an increased blood pressure. We have also degenerative conditions as the arterial disease or atherosclerosis that may increase the blood pressure because the arteries become hardened in time and have reduced vascular compliance. We may have tumors of the adrenal medulla that will increase the secretion of stress hormones as epinephrine, which is part of the sympathetic nervous system that by their action of increasing the heart rate and increasing the vasoconstriction will create the increased blood pressure. Whenever we have hypertension that has no existent, no apparent medical cause, we'll call it essential hypertension. And we believe that usually with aging, there is an excess of an enzyme that is called renin that is produced in the kidney. And this enzyme probably is the cause for essential hypertension showing up in some of our patients. What would be some treatments for hypertension? Well, first of all, we need to see what caused the hypertension, and if there is an apparent cause for that, we need to treat the apparent cause. If it's not, we will need to treat the essential hypertension with medication and to lower the blood pressure. We have some guidelines for that, and we define a person that has a reading in between 120 and 139 for the systolic values, or between 80 and 89 for the diastolic values. So keep in mind that I can have someone that have 110, so the systolic is good, but the diastolic pressure is 90 or 91 or 95. That's defined as hypertension. So whatever I have in between 120 and 139 for systolic and or 80 and 89 for diastolic is defined as pre-hypertension, and the treatment will be lifestyle modification by modifying the patient's diet, encouraging them to exercise more, stop smoking, and low sodium in their diet, pretty much no medication but lifestyle modification. And we have what is called a pure defined hypertension, and that will be in the case of a patient that has measurements of 140 or over for systolic or 90 and over for diastolic values. In this case, for this type of patients, beside the lifestyle modifications that will always help, and they are always a part of the education and the recommendation, will add drug therapy. And in the drug therapy, we can add what is called a diuretic, which is a drug that promotes salt and water loss through the kidneys. The second line would be those drugs that limit production of renin or block its action. So they are um, um, drugs that act and influence the activity of the kidneys. And we may have drugs that relax the blood vessels, including adrenergic blockers and calcium channel blockers that will produce a vasodilation, will increase the diameter of the blood vessels. We'll discuss now the vascular disorders, and there is a variety of underlying disease processes that at a certain point will develop into vascular disorders. And the underlying disease can be hypertension or diabetes, and they all contribute and work together into the development of pathology of the vascular system. You have them named here. However, I will discuss them one by one um, in the next slides. I will start, however, discussing a little bit here the hemorrhage. And the hemorrhage or the bleeding is the a profuse escape of blood from the blood vessels. A bleeding can be, or a hemorrhage can be internal or external. It can happen from vessels of any side and may involve any part of the body. Whenever a blood vessel is injured and the escape of the blood is not stopped, we define that as a hemorrhage. In a capillary that has a very small diameter and a very thin wall, collapsible wall, the hemorrhage can be stopped pretty easy and quick by a process that is called a clot formation. With loss of a small amount of blood, most probably nothing will happen to a healthy adult. However, the symptoms and signs depend on not only on the amount of blood that the patient will lose, but also on the speed that they are losing the blood. So a rapid loss of about a liter or more may be life-threatening by affecting the brain irreversibly. If you remember from chapter 13, when we discussed, 13, when we discussed the blood, you remember that we said that on an average, an adult male will have about 5 liters of blood. So can you imagine losing a liter and very quick? In terms of treatment of hemorrhage, usually we can, in an acute setup, we can apply pressure and the artery that is damaged will be compressed. It's very good if that artery is close to a bony prominence, so that will slow or even stop the pressure. Like even stop the bleeding. Another condition will be the shock, and shock can have a lot of meanings when we are using it in the medical field. However, whenever we are using the term shock, we try to refer to a life-threatening condition that is characterized by an inadequate blood flow to the body tissue and especially to the brain and the heart. Also, the kidneys can be involved. They are also essential, but the brain and the heart are the essential elements that cannot be left without the blood supply that brings the oxygen. Based on we classified the shocks in different types based on their mechanism of production and what generates them. We have what is called a cardiogenic shock, and this is considered to be the leading cause for death when we are looking at the shock conditions. And it happens when the ventricles are not able to pump blood efficiently. It's that type of shock that happens in a very, very sick heart that is not able to work anymore, is giving up. It's usually a complication of a heart muscle damage, and it happens mainly in patients that have extensive myocardial infarction. Another type of shock would be the septic shock. It's categorized as the second um, most deadly type of shock. Is a result of an overwhelming bacterial infection in the entire body. The hypovolemic shock is caused by a decrease in the overall blood volume, may follow severe hemorrhages or burns or any type of condition where the body is losing a lot of fluids that are not replaced efficiently. And we have another type that is called the anaphylactic shock, and this is a severe allergic reaction to a foreign substance that the body responds to that. In most of the time, in severe shocks, the body is trying to compensate, and when the um, the death happens, is because the compensatory mechanisms will fail to maintain adequate blood pressure. We have another condition that happens at the level of the in a blood vessel. It can be in an artery or a vein, and it's called thrombosis. Thrombosis is the formation of a blood clot in a blood vessel. If it's in the deep venous system, it will be called a deep vein thrombosis. However, it can happen in arteries also. A dangerous complication of thrombosis usually happens when um, the blood vessel will form what is called an embolus. And the embolus is a piece of the clot that will break out from the original blood clot and will float in the blood up to a different structure. And it can lodge in another vessel. Usually they will lodge at the level of the pulmonary arteries, and by doing that, most of the times will be a sudden death. They can lodge at the level of the heart in the coronary arteries, and as a result of that, we have a myocardial infarction, or at the level of the brain vessels, generating a stroke. In the treatment of thrombosis and embolism, we use anticoagulants, those medications that will reduce the capacity of the blood to coagulate and will try to, and other medication will be called thrombolytic, will completely dissolve the thrombus also. And if you remember, we discussed them in chapter 13. We have anticoagulants as heparin or warfarin, Coumadin, and we have thrombolytics that are dissolving the thrombin clot. Whenever there is an inflammation of a vein that may contribute to a clot formation later, that's called a phlebitis. And when we have a clot that forms in a deep vein, we call it a thrombophlebitis. The varicose veins, we'll discuss them in a second. Now to discuss again a little bit about the atherosclerosis and how this affects the blood vessels. So we call atherosclerosis as a degenerative condition of the arteries. Is characterized by deposits of fatty plaques that in time become calcified with calcium salts and with hard tissue, scar tissue that will harden the arteries and will make them incapable of expanding and contracting back. And you can see in this picture the atheromas is compared with the other blood vessels, that you can see how smooth and nice and clean it is. And look at the other one, how it looks all damaged and dirty. The atherosclerosis can happen everywhere in our body, and this starts pretty early in our life, in our late 20s and beginning of the 30s, depending on all kinds of elements. If you remember from the heart, depending on our genetics and our diets. If you remember the diets, high in fat and saturated fat will have a higher chance to develop atherosclerosis. There are several signs and symptoms of depending on the organ that is more affected. And when a blood vessel is compromised like that, it will not going to provide enough blood flow to a specific organ. So if we are talking about the arteries of the lower limbs, if they are not providing enough oxygen, the patient will complain of pain and leg cramps and what is called a sudden lameness. When the affected blood vessel is one of the brain or neck main vessels, the patients will come and complain of headaches, dizziness, mental disorders, loss of consciousness, depending on the size of the blood vessel that is affected and the position of it. Hypertension can also develop as a result of atheromas and decreased contractility, I'm sorry, compliance of the blood vessels. At the level of the heart, compromised blood flow to the heart will create all the signs of symptoms of heart failure with palpitation and dyspnea. Another condition of that can be encountered regarding circulatory system will be an aneurysm. And the aneurysms are bulging sacs in a blood vessel's wall, and that they are mainly caused by weakness in that part of the vessel as a lack or destroy of the muscular layer at that side. The most common sites for aneurysms will be aorta and at the level of the brain vessels. Once the damage to the wall is done, that can be fixed only through surgical procedures. Those aneurysms can be result of congenital conditions. We may be born like that, or they can be the result of atherosclerosis and in some cases of injury, of trauma. In terms of surgery, we can do major surgery that will be open type of surgery, or we can use a minimally invasive through catheterization. The varicose veins, or the varices, are superficial veins that are inflamed and swollen and distorted, and bottom line, ineffective. And they are the result of valvular damage that allows the blood to pull down in those vessels instead of being pushed up towards the heart. The saphenous vein of the legs are most commonly involved, and most commonly the greater saphenous vein, the one that runs on the medial side of the legs, is affected. It's very common in people that are standing for very long periods of times, like salespeople and nurses. A lot of times is because of the action of gravity and the lack of muscle contraction sometimes to push up the blood. Also, they may become exacerbated or show up in pregnancy due to a compression by the pregnant uterus on the pelvic vein. The varicose veins that will show up at the level of the perineum and especially at the level of the rectum and the anal area, they are called hemorrhoids, and they are actually varicose veins of that area. Another part of the body that may manifest with varicose veins is at the level of the lower esophagus, and it's a result of increased blood pressure, hypertension in the portal system that is caused by the a liver disease in cirrhosis patients.